So good morning, everybody, and welcome this morning to the last, I think, of our Emerging Scholar talks as part of the programme. And it's my pleasure to introduce Elinore Kaufman this morning. Elinore is an assistant professor of surgery at the University of Pennsylvania, where she works as a trauma surgeon and health services researcher. Her work's focused on reducing harm from injury and violence, including injury prevention and interventions to support holistic healing. She holds an MD from Harvard and a Master's in Health Policy from Penn, where she also completed her fellowship in trauma surgery and surgical critical care. And she serves as the medical director of the Penn Trauma Violence Recovery Programme, which provides individualised support and case management to survivors of violent injury. And I asked Dr. Kaufman for a fun fact that I could share to open today with, and I can let you know she's a ubiquitous knitter and enjoys knitting strange objects like bricks, walls and cement blocks, which seems to tie in with this opening slide. So over to you, Dr. Kaufman. Sorry.
No, thank you so much.
Okay.
I don't know. Good morning. I'm Elinore Kaufman. Thank you so much for having me. It's really exciting, and it's an honor to be here. I have heard that there are people, when they think of the University of Michigan, they think of like sports ball or whatever, but I definitely think of research, and maybe specifically health services research, when I think about the University of Michigan. So it's really cool to be here. I am feeling like some kind of way this morning, though, as I'm visiting you from the University of Pennsylvania, which is no institution is perfect, but it's a place I have really enjoyed working for, and still do. I'm not like leaving. But today is the day, I guess, when Penn decided to clear our student encampment, and it's kind of heartbreaking. I've been so impressed with what the students have put together. Anyway, not super relevant, but true. So I think I know a few of you. So I know we have a few injury people. I think probably not a lot of surgeons in the audience today. Is that true? Yeah, it's not surgery o'clock, or it is. We have. Is this weird? Who's a clinician? Okay, and everybody else is a serious scientist. Damn it. So I'm going to try to talk about some things that I thought would be of potentially like broad appeal. I also realized as I was going back over this talk, like this is called here's an emerging scholar. This is very emerging work, none of which is done. So this is like a lot of concepts and not a lot of results, but hopefully it'll be interesting. I don't really have anything to disclose that is actually relevant. I'm fortunate at the moment to have some assorted funding from around, and I am recently, as of recently, a board member of one of our local firearm injury prevention advocacy groups. But the concept that I'm thinking about today is I'm a surgeon. I'm a general surgeon. Specifically, I do trauma and acute care surgery. And so almost all of my patients are experiencing an emergency come to us through the emergency room. We're not planning to see a doctor today. I mean, every once in a while I do something scheduled. And so I've been thinking a lot about, when and why and how can an acute care encounter be more than acute care. So I'm going to talk about a little bit of motivation, and then I'm going to talk about three kind of unrelated examples. This is a intimate group. You should feel free to interrupt me and ask questions. I will also do my best to not talk too much, and I will do my best to remember to pause at least after each topic and try to talk about them. And these are all emerging things, so I'm welcoming input. So this is like for those of you who are clinicians, I assume you're here because you're a physician scientist, you're on some clinical research policy spectrum. It's like providing excellent healthcare is great, is challenging, is rewarding, is interesting, but I'm always wondering, like, how important is it? Like, it's important in the moment, and it's important to the patient in front of you, and that's really meaningful, but probably a lot of you have seen something like this before too, right? So healthcare accounts for something like 10% of what actually contributes to people's health outcomes, and there's all these other things, right? There's people's health behaviors. Here it says 20%, but like, a lot of that is access to care, and only some of that is like actually what we do. So I think that's why I said 10% there. And then there's all these enormous, right, social and economic factors, physical environment, all of that stuff, right? All these social determinants of health, which are the conditions under which people are born, grow, live, work, age. There's things like education, access to care, economics, social support, physical environment, and sort of like the structural determinants of health inequities that feed into those social determinants. And these are like the social, economic, and political mechanisms that generate inequality in society, inequality across the board, and then inequality in health. And so I really do like providing health care, and then I really do think a lot about its limitations. And these are kind of topics that we think about and talk about and are sad about and sometimes put into models. But I think the question is really like, when and in what contexts might these conditions that are determining so much of people's health and experience in life actually intervenable? When I was in medical school, I got a lot of teaching from the people who founded Partners in Health, which is a really wonderful global health organization. And this is a slide stolen from their work, right? In which I thought that they thought in a really smart way about how social justice and medical care might fit together, with the idea that we strive to ease suffering by providing a comprehensive model of care that includes all this other stuff, access to food, transportation, housing, other key components of healing, while also bringing the benefits of modern medicine to those who have suffered from all these injustices in the world. This is an internationally focused organization. When I was in medical school, I worked for in Boston, I worked for their Boston arm, which I don't think exists anymore, but the United States is part of the globe, and we have global health here too, and plenty of inequity of our own, right? I wasn't sure if the people involved in this next slide would be here, but some additional inspiration and some inspiring mentors thinking about how you might intervene on these conditions include Doug and Michelle have been part of this. The work out of the University of Pennsylvania by Charlie Brandis and others of greening vacant lots to improve health. So maybe not Ann Arbor, but certainly Detroit, right? And Philadelphia, like many other cities, have had population loss over time. Now we have population growth, but there's a lot of abandoned land, a lot of empty land. And vacant lots are not appealing to the eye. They're not a good sign about the neighborhood that they're in. And you can imagine, I don't know, lots of things that you might do with land. But the question that this team had is, if we just fix it up, clean it up, green it up, does it improve people's health? And, really aspirational to run a randomized trial of a structural intervention was done, did work, right? So perceptions of they did it really well. Just trust me, or I can go into it. But it's not just on the lot, right? And there is some like direct lot effect, like your group or gang is hiding its illegal weapons on the lot. So there's some direct effect probably. But they looked at it at the neighborhood level. So perceptions of crime, safety concerns went down. All crimes went down. Gun assaults went down. And they went down more in neighborhoods below the poverty line, which I think is really encouraging. And then there's all these other things, like people felt less depressed and had better blood pressure control, all this stuff. Anyway, so this is kind of just motivation that makes me think about, like, what we can do that's more than what we think we can do. So example number one that I've been thinking about and working on is what happens to people who survive an injury due to violence? A lot of what I think about is firearm violence. There's other mechanisms of violence as well, but we've got a lot of guns in Philadelphia. But 95, and we think a lot about deaths due to gun violence, but 95 to 97% of people who make it to the hospital survive. And as a physician and as a surgeon, that's like success to me, right? So we maybe even take someone to the operating room and remove their spleen or some other organs. We were talking about spleens at dinner last night. And we do all this stuff, and there's lots of drama, and we spend a lot of time thinking about how to do that better, as we should. And then we, like in the best case scenario, discharge someone home. But this firearm violence and violent injury is a structurally determined disease. So people were at risk because they live in a neighborhood that we collectively as a society have made extremely dangerous for them, basically. There's other factors too, right? And they go back, if we win, they go back home, which is to the exact same situation they were in before that maybe was never safe for them, but is now manifestly dangerous because they've already gotten shot, usually close to home, sometimes in their home, right? And then the injury itself doesn't make it better, right? It makes it worse. They have physical recovery, they have all sorts of mental, social, and economic challenges that put people at risk for worsening of those social determinants of health, and also put people at risk for re-injury. And so this is some work from colleagues at Penn. It's a little bit of a hard graph to read, but these are percents of people doing worse than population norms across all these different domains, and they're high. That's the whole point of it, right? About 50% of survivors of civilian violence develop depression or PTSD, which is right on par with our military veterans, and maybe not surprisingly so, but a little bit surprisingly so if you haven't thought about it before. One of the best papers that I've ever read is this paper by John Rich and Gray about this thing that we worry about a lot in our field, which is people getting re-injured, because it is just such a bummer, right? To take care of someone and think you've done a good job and then see them again for the same problem. It happens across medicine, right? Like the greatest risk for having a heart attack is having already had a heart attack. And unfortunately, it's quite true in violent injury as well. But when people have symptoms of traumatic stress, that's not managed, right? They have a disrupted sense of safety. They may be more likely to self-medicate and self-manage with substances that lead them down, lead them into illicit economies. They may be legitimately in fear of their life and safety, making them more likely to carry a weapon. Many of us in the injury space don't think that carrying a weapon actually makes you safer, but it's very much people's perception, right? Which also puts them at risk for being involved in retaliatory violence, for using that weapon, for being involved in criminal justice situations. People don't tend to feel like they can rely on the institutions that are supposed to protect them, be it police, probably also be it healthcare, right, and are at risk for re-injury. This sort of set of phenomena has led to the development over the last couple of decades of these programs called hospital-based violence intervention programs, with the idea that dedicated support can improve people's recovery. These are kind of on, if the community health worker model, so these are trained lay people. The core of the programs are trained lay people, not medical professionals, who come from some sort of shared background and experience with the people we're taking care of, who can form connections with people at their worst moments, and provide a combination of psychosocial support and case management services to connect people to the resources that they may need. Thank goodness. Well, so there's some evidence that these programs may work. Reduction in misdemeanors and aggression, people are less likely to be convicted of violent crimes, they have improved self-efficacy, decreased substance use, and these numbers decrease recurrent injury from assorted randomized trials. I will say, since Dr. Goldstick is in the front row, although Dr. Cunningham is no longer at this institution, that this evidence is all pretty bad and controversial in a niche field in which we live. But I would say, working in one of these programs, it is really hard to argue with things like this, right? So this is shared with permission. This is one of our early patients in our program at his high school graduation. And it's hard to run a randomized trial on getting firearm injured kids to their high school graduation, but it's also really hard to imagine, knowing this kid, that it would have happened without the support that he got. So this is like a sort of interesting meta question about like how we should be studying this kind of thing and what the right outcomes are, and whether we should randomize people to something that feels really basic, or whether the evidence needs to go somewhere else. We don't do randomized trials of like, should you see a hospital social worker? Should you have a nurse? I don't know. It's not quite at that level, like you need to have a nurse, right? But these are some of the things that these programs do. Programs are different. The individual and they all run, though, on individualized goal setting. So a lot of people need mental health care, victims of crime compensation, employment is a big concern, housing is a big concern, education is a big concern. This was a program from California, so tattoo removal is not a big thing in Philadelphia where I work. We don't have that kind of gang, but this is people trying to get out of gangs, right? So we didn't have this kind of program at Penn. We founded ours in 2021 with support from the Pennsylvania Commission on Crime and Delinquency, which is quite a name, but that's where the violence prevention funds live in our state. And we hired one person, and thank goodness it was Rodney, because he is amazing, and he did give me $5 to include this in the talk. He is really, we could not have run it without him, and if we had someone less even-keeled in the role, it would have been a real struggle. But our first question was sort of like, would people like it? And would our clinicians like it? Would our patients like it? And they did. So as we were developing the program, we got involved in a citywide coalition of similar programs. Philadelphia has 6 level 1 trauma centers, and all of which have some type of program. We did. I'll talk a little bit about where we're trying to go with this, but we learned very quickly that people need money for really basic stuff. And so one of the first things that we were able to expand to was sort of a patient needs fund. And we spend a lot of money that way on, like, things you wish you didn't have to, on groceries and clothes and whatever. And Penn also formed at that time, through our Penn Injury Science Center, community violence intervention program. So we're able to bridge a little bit from street outreach to in-hospital outreach. And it went pretty well. We were funded to expand. We added 3 more violence recovery specialists and added some dedicated mental health resources, which I'll talk about a little bit more in a second. This is our current, yes, this is an accurate picture of our current team. Yes, and some of our many, many partners that we work with. So this is like, non-evidence stuff that I'm talking about, early learning. So staff and patients were extremely receptive to services, but we did find that the most common needs were like the things that were in some ways hardest to meet. So lots and lots of people wanted mental health care, which is not surprising in a way, because I told you people have pretty serious mental health effects, but mental illness is pretty stigmatized, and seeking therapy is pretty stigmatized, and I wasn't convinced that people would want it, but people do. Not every single person, but people mostly do. They're like, hey, I have PTSD. And I'm like, maybe you do, maybe you don't, but it sounds like you probably need to talk to someone. So we were able to, so Penn has a lot of centers, like the University of Michigan also has a lot of institutes, I believe. But we have a Center for the Treatment and Study of Anxiety, which is one of the world's leading PTSD centers, and they are wonderful, and they have historically been cash only, and so not super accessible to our patients. There's tons of wonderful mental health providers in our area, many of whom do take insurance or do have free services, but as I think this is a national situation, right, there's a shortage. And so telling someone who's suffering that I can refer you to therapy and they will see you in 3 months is really not a great start. So we were able to partner with the CTSA to cobble together some dedicated therapist resources. So we now have a little cadre of therapists who will pick up people inpatient, talk to them a little bit, see if it makes sense to follow them outpatient, and I have no evidence to share about that. I'm excited about it. I think it's cool. It seems like it's working at least to get people connected to care, and we'll see how it sorts out. A lot of no-show visits, as you could imagine. That's a challenge, but a lot of visits happening as well. And because it is free therapy, people probably no-show more. But because it is free therapy, our therapists have a lot of flexibility. So there was one patient who was in, for a long time in such a profound situation that our therapist was seeing her 5 days a week in various locations. Our therapist was accompanying her to her court. This was a patient who had to go to court as a witness against the person who assaulted her in a pretty bad way, right? And so our therapist was accompanying her to court. So it's very much as like, then we're like trying to find training for our therapists on court advocacy. So it's like, what is healthcare for? I don't know, but it's pretty cool. It's pretty cool stuff. That patient got to a point where she was no longer thinking about suicide on a daily basis. She did end up in inpatient psych for a couple of weeks, which is not surprising and not, obviously I wish she didn't need it, but not bad that she got it when she needed it. She's back out again. And so, I don't know, we kind of think collectively between the trauma team that treated her injuries and the mental health team that treated her really severe symptoms, maybe we've saved her life twice. We'll see how it goes. The second most common, these vying for 1 and 2, are mental health and housing and relocation. So I told you we're discharging people to places where they got it, right? So many people came from sort of unstable, insecure housing situations to begin with, but also many people would like to relocate for safety, either because there's an individual that they know shot them, that they don't want to be able to find them, or because they don't know who shot them and they still think whoever that person is looking for them, or many, like a lot of our patients, this may sound too, I don't know, too optimistic. That's not the right word. I believe it, that many of our patients are shot by essentially stray bullets. They're mistaken targets. There are shots being fired and they hit unintended targets. So a lot of our patients are really going about their daily lives when a bullet hits them. Some people are also going about their daily lives and having an argument where they and or someone else pull a gun, right? Which is, you should be able to have an argument without it becoming a life-threatening situation. So I'm not saying there's something bad about those patients either, but I think when you're sitting on your porch or you're at the corner store or you're doing your laundry or you're at your birthday party, these are all real examples, right? And you get shot in that circumstance, it really is a profound disruption to anything resembling a sense of safety. So people want to move, either temporarily or permanently. So we have a pretty strong partnership with a program out of our DA's office that helps people relocate. There's a couple other programs around the city. They're all underfunded. They all run out of money. So we got kind of a bonus sort of surprise grant from a local foundation, and so we are piloting a direct relocation assistance program in which we're not, we can't pay people's rent forever through this program, but we can give people, we're doing like $2,000, so we can give people like first and last month, hopefully get them over the hump to a new place. We've had like 3 people who've gone through this so far, so I don't know, we'll see. I also would like to develop an understanding of their experience with that program. I've told my team I cannot start another qualitative study until we finish a qualitative study. So we'll see what we can learn from these participants in a little bit. And then people need money. I already said this. People need money for their phone bill. People need money for groceries. People need money because their driver's license was lost or confiscated and they need to pay the $60 to get a new one. And it's like a real barrier because if you don't have your ID, you can't sign up for anything else, right? People need money for their rent. People need whatever. So we have a patient needs fund, which has been, I guess, successful, right? I don't know. I mean, we give money to people and they spend it on things, which I think is a bonus. And this is kind of where we're at. These are these are January, it's not January 2023, it's January 2024 numbers. But our team saw about 400 people at bedside, and about a quarter of them enrolled in the program in a durable way. And the violence recovery specialists will meet with people for inpatient and then outpatient for months. Refer people to a whole bunch of resources, and at least 46 of them saw a therapist at least once. So that's kind of where we're at the moment. And then things that we're looking at, I told you about the housing support pilot. Another pilot program that we're involved in that I'm really excited about through the Philadelphia Department of Public Health is a guaranteed income program. So guaranteed income is exactly what it sounds like. It's an unconditional cash transfer. And these have been growing in popularity in a lot of different areas. Probably more established in the international space than in the U.S., but there have been a number of really interesting experiments in guaranteed income in the U.S. with some growing momentum. It hasn't been done yet really with a focus on violence, and disappointingly to me, most of the pilots that have happened haven't measured violence outcomes, which is, I feel like it should have an effect, so we're trying to work on our colleagues to get them to measure it. But yeah, and that's our team. So violence is heavily determined by poverty. Interventions rarely address it, and we think that providing income support to survivors will help them meet their basic needs, alleviate financial stress, but also allow them to focus more on the things that they need to do for recovery. And that's kind of in other types of guaranteed income studies, people who receive guaranteed income are more likely to end up with full-time employment because it doesn't make them lazy. It gives them the mental and physical and sort of logistical space to take those steps. So we're hoping that that'll carry over to recovery. We've enrolled, I think, 41 of our 50 pilot participants. This is more of a feasibility, and there was a lot of feasibility involved in getting this started, but super cool, very exciting. And then we want to do it bigger. The other thing that we're really excited about, and this is sort of a niche violence recovery program type of thing, which may be less relevant to this group, is that the federal government is now allowing states to use Medicaid funds to pay for violence recovery services, violence intervention services, violence prevention services, so that our violence recovery specialists could bill on some level for their care the way I do. I mean, I don't do anything, thank goodness. The University of Pennsylvania does that for me. But states have to opt in, and every state is different. I don't know that this has been started in Michigan. It may have been. Connecticut is the furthest along, but in Pennsylvania, we're pretty sure that we can do it without new legislation. We can do it from an administrative standpoint. So we're now in the process of defining the role and defining the benefit so that billing can occur. We probably won't be able to bill enough to cover the entire cost of the program, but it could be a real blow for sustainability. And that is a picture of us with the former governor of Pennsylvania outside of his office because the fire alarm went off during our meeting and we had to evacuate the building. Fire alarms go off all the time, so we're all in there looking around being is this a real thing? And then the government people were like, no, we have to evacuate the governor. So we did. So that is all I have to say about violence recovery programs, not really, but for now. Thoughts or questions? And I'll talk about something totally different. All right, no thoughts, no questions. I'm going to talk about something totally different. Do you guys have this? Does this look familiar? Do you have metal detectors or weapon screeners at your hospitals or your... Man. So this... You do? Somewhere? Yeah. Yeah, so... In the ED. We have more and more of them across the health system at Penn. These come from concerns about workplace safety, right? Everybody has probably heard stories of shootings in hospitals. Nobody ever wants to hear one again, right? They're very annoying to go through. Your laptop sets them off. They're supposed to be a little more specific to weapons and not just be metal detectors, but your laptop will definitely set them off. And so it's annoying to me, which is, I'm glad that I have the following research program to talk about because it makes me feel better about the experience. I don't know if this is the right or a right intervention for workplace violence, and anecdotally, it may not be totally successful at that. But what it is very interesting. And so what I'm going to be talking about related to that is secure storage of firearms. So we got some firearm people in the audience, but some non-firearm people in the audience. Some of the firearm people in the back row of this audience have generated some of this evidence, which I'm going to summarize very briefly here. But there are more firearms than there are people in the United States. I am totally upfront with my biases, which are evidence-based biases, I think, say I wish there were no guns in the United States. I'm not like, I think the risks really outweigh the benefits when it comes to living with firearms, but I don't think that that is going to be a winning argument anytime soon. So I think efforts to improve the experience of living with firearms are very worthwhile. If you have a gun in the home, though, you're at double the risk of experiencing homicide, triple the risk of experiencing suicide, 5 times more likely to be shot in an assault, 7 times higher risk of intimate partner homicide. The most common reason, people own firearms for all kinds of reasons, right? People are hunters, people are collectors. The most common reason is for personal protection. To me, it's a bit of a everybody thinks they're an above average driver thing, though. Like everybody thinks they're the one who's going to be able to defend their home in a home invasion, and somebody out there may be that person. I do think that firearm advocates are looking really hard for those stories and not finding them, and there is really no evidence in favor of the concept of defensive gun use as at least a population level way to improve safety. Really, it increases your risk of all of these things. Secure storage of firearms doesn't take firearms away from anyone, but it does have the potential to reduce rates of youth suicide, of unintentional injury, and it's less related to community violence, which is the thing I think about the most, but there is a route from unsecured firearms to gun theft to the use of gun in crimes. Gun theft is a pretty important route to crime, so I think this is not trivial. Suicide is not my area of expertise, but anytime that I'm talking to an audience that I think might not know, I think it's worth saying suicide is the most common form of firearm death. Firearms are by far the most lethal means of suicide. 90% of people who attempt suicide with a firearm die. However, suicide can be related to serious mental illness, long-term distress, but for most people, the actual suicidal impulse is very short-lived. Less than a day, less than a few hours in many, many cases. So if a person who's at risk of suicide can be separated from lethal means during their time of crisis, they are very likely to be a long-term survivor and have that second chance, have the opportunity for mental health care, for intervention, for whatever they may need, right? Because the other 90% is 90% of people who survive even a suicide attempt are long-term survivors. Only 10% of people go on to die by suicide later. So it really is a important, time-sensitive intervention that's available to us. Youth suicide in particular I'm talking about in terms of secure storage of firearms because most youth cannot and do not go out and get their own firearm when they're in this time of distress. They get a firearm from their own household or from the household of someone they know. I don't go to Harrisburg that much, but I was in Harrisburg again this week for a firearm injury advocacy event at the Capitol, and one of the speakers at our rally was the parent of a teenager who died by suicide during a breakup, right? It didn't need to happen, right? But there was a gun and he grabbed it, kind of thing. So secure storage is what I'm talking about. Skip this thing. The best way of storing a firearm is locked and unloaded and separated from ammunition. It's not that common, though. You can think about what you think this graph is going to look like. Less than half of families, less than half of households with firearms store them in the ideal manner, and it's not that much better when there are kids in the house. Kids find their Christmas presents. Kids will find the gun on top of the refrigerator, the gun in the back of the closet, right? And we've all heard those stories. And so this is this idea that health system interventions to enhance secure storage can work. There are lots of pediatric practices and other settings that are counseling patients and families about firearm storage. People are open to talking to their doctors about guns, not every person, but for the clinicians in the room, we talk to our patients about lots of sensitive subjects, and sometimes they don't want to talk about them, and that's okay. But about 60-70% of people are willing to have this conversation. And after there's some evidence that it's helpful. All of this evidence is going to be self-report, so there's some that's not straightforward. But after receiving a free cable lock, which is this little blue thing, blue locking device in the picture, about 40% of people securely stored their firearms. And, even a modest increase in safe storage could prevent an important number of firearm injury deaths in children. Firearm injury is now the leading cause of death in children. So at Penn, there are ongoing efforts in our department in trauma and family medicine, the pediatric ED, the PICU, the primary care, the NICU. And I'm not this smart. But my colleague and friend Tor Kit Delgado is, because I saw these weapon screeners and I thought, that's very annoying. And he saw these weapon screeners and thought, that's an opportunity. Over the first 5 months, this is Pennsylvania Hospital. It's one of the hospitals in our health system. It's in downtown Philadelphia. It just looks bucolic. Founded by Ben Franklin. It's the oldest hospital in the country. And it's kind of like got a community hospital feel. And that was the first hospital where we introduced these weapon screening devices. How many firearms do you think were identified? 408 in the first 5 months. This is not people coming in trying to shoot up the hospital, right? These are people who are carrying guns because they always carry guns. Some of them may be people carrying guns because they're coming into Philadelphia and they're scared, or whatever. And people just don't think that maybe it's not a good idea to bring this into the hospital. So it's not so much that this was a huge danger, but it is potentially a big opportunity. This is a couple of guns a day. And so because Kit is smart, we reached out to the security team at Pennsylvania Hospital to form this collaboration where we are offering safety information and a free gun lock to people who are identified to have a gun with them. They are, by definition, not securing their guns. They are, by definition, a high-risk population, right? So it's very focused intervention in that way. Well, I'm going to tell you there's a little bit less focus to it now, but pretty cool. I think it's cool. This is our little brochure about how you use a cable lock and why it's a good idea. This is brochure 2.0. I just updated this slide, and brochure 1.0 was a lot worse. This one is cool. We have this very cool designer working with us. Anyway, and since July 2022, this is really embraced by the security team. I'm going to show you some more about that. The coolest part is this collaboration. They distributed more than 300 cable locks. About half of the people that they offered them to took them. And then we had some funding to do more with this. Some of you were at the conference of the Research Society for the Prevention of Firearm-Related Harms last year. I've never been at a conference that was covered by an editorial in the Washington Post before, but this was neat. So, and our project was one of the projects that they talked about anonymously, but that's pretty cool. I think somebody made it happen. It wasn't me. So we've been working on this. This is our team at a sort of a design session. I told you the partnership with the security team is the best part. They just absolutely have taken this on as part of their mission and a way to expand their role. And they're really they have like a bit of authority to them, but they're not law enforcement. So I think it's a really cool little role. So overall, it's very well accepted. Very people have declined it. There are more numbers of people saying yes. And they do all this like behavioral thinking without being taught that much. If you say, would you like a gun lock or no, they'd be like, yeah. But if you say, here, take this gun lock with you, it's on us. I think you'll get more out of it. Right? It's very cool stuff. And And, they really believe in it. I believe it can help for the safety of yourself, but the reality of it is that you're not going to have time to unlock. I believe every owner has a weapon where they can get to it right away. So this is sort of like the concern that we're talking about. And then they're like, we want to have gun safety classes at the hospital. We haven't done that yet. Because I ran into a couple of patients that didn't have a clue on how to get the magazine out, but they're still carrying it. So super interesting. So the good news about the next step is that we've just launched some data collection on this. Again, it's going to be self-report, right? Because we cannot go into people's homes and see how they're storing their guns. Those pill bottles that will tell you when they're opened? You probably technologically could do that with a gun lock, but not going to happen. Yeah, it's probably expensive, but it's also a massive privacy concern, and patients are not going to agree to that, right? And then so this is the cable lock. They're cheap, they're small, they're easy to distribute. They're the most commonly distributed things. They are not the most popular among gun owners because, like I said, people think they're going to grab their gun and defend themselves super fast, and they think this is too fiddly. And telling them that they're wrong is not that successful. Lockboxes are probably a little more popular with firearm owners. You can store a gun in it loaded. That's not what I think you should do, but you can, and it's still better than storing your loaded gun under your pillow. And you can, there's a code, or there's a key, or there's a biometric thingy. And so we did get funding, which is trapped in our legal department, but it's making progress, to purchase lockboxes to distribute, and we have a little thing where we are working on randomizing people to either just get a cable lock or have the opportunity to choose their device so we can get a little firsthand information on their preferences, which I'm excited about. That is just starting last week. And we've got lots of opportunities to explore design questions. So lots of good news. In other news, this was working, and I don't think I even articulated this because I'm talking too much. This was working during a kind of in-depth interaction with the security officer in which the person was coming in with their gun. They were saying, you can't bring that in here, and taking them to a locking area to store the gun on site during their visit to the hospital. That's kind of an extended interaction, but they're no longer allowed to do that. And so now the interaction is you and your gun have to leave. Maybe some of those guns are ending up where they used to end up, which are in the bushes outside the hospital. Maybe people are putting them back in their cars. Not ideal. Anyway, so it's the quality of the interaction has changed, and the quality of our intervention, or the nature of our intervention, has to change as well. So now we are, on the other hand, this does allow us the opportunity to scale this up to people who may have guns but are not carrying them with them today, and to other facilities and other parts of our healthcare system and other places outside the healthcare system. So information pending on that. That's the end of what I have to say about gun lock distribution for now. I'm going to pause again and see if I can generate questions. Thank you.
I'm thinking about how you could try to study the impact of this, and it's really challenging, right? Because you can't ethically randomize people to get a cable lock or not, right? Because we don't really truly have, I would argue we probably don't really truly have equipoise to do nothing in what we know is an unsafe situation, right? Mm-hmm. But I do wonder if there is an opportunity for I don't know, maybe comparing it to if you could get data on hospitals that have maybe if Evolve, that system, could share data with you from hospitals that don't have a program like this in place, and you could compare something. I don't know, then you reach out to those patients or something. It's such a cool program, and it sounds really hard to study, and I'm just trying to.
So there's more and more of this going on, and more sort of messaging about it, and so there's more and more, I hope, opportunities for us to say, hey, you have a doctor's appointment, and it's called My Pen Medicine, and your automated notification told you not to bring your gun. Click here for a free gun lock, right? And there's all sorts of, I think, opportunities to vary that design and do different things with it. Ultimately, I don't think we're going to measure an impact on like gun injuries in Pennsylvania, right? That would be hard to perceive. So I do think the best thing we're going to get is if we can get people to fill out a follow-up survey and tell us, did they use it or not, which is hard enough to get and then still on a fundamental level is unreliable information. I don't know. Doug and Michelle.
Question, Elinore. I'm so glad you're here. My name's Doug Weeb. I direct to others. My name's Doug Weeb. I direct the Injury Prevention Center that's just down the hall. I worked with Elinore for years and years at University of Pennsylvania before I came here a year and a half ago. You know, in part to your question, it has me, and I'm thinking about bigger picture stuff, Elinore. Mm-hmm. How can you even be able to run a trial on this kind of thing in a health system? And with your firearm injury recovery program too, it's astounding, and they're so lucky to have you, that you've stood up such a strong program. You as an individual, a trauma surgeon, need to have protected time to run it.
I gave him $5 too.
You'll need office space and all sorts of more stuff. I'm thinking about the 50-year plan, or maybe you can do it in 5, but especially being here at the Institute for Healthcare Policy and Innovation, how can you carry your program to all of the other trauma centers across the United States and scale this up? You've got such good momentum because it's a special little place in Penn, big place in Penn. Yeah. But how does the field start to introduce this? It was a big plus that you mentioned using healthcare to pay for something, I don't remember. Yeah. But you know, back to you on that. How can we work this into the system?
That's a good question that I don't know the answer to. I do think the thing I was just talking about in terms of the storage intervention is we're working hard on it, but it ultimately is like a fairly affordable, fairly low-touch intervention that has been very appealing to our health system because they want to do something about workplace violence. They want to do something for the community. They've latched onto this, and I think it's potentially very scalable. That doesn't explain how to pay for it, except that I think it won't cost that much. And I think could potentially be appealing to lots of institutions. So I don't know. And then the thing about Medicaid funding for violence intervention, I would say it was the result of long-term hefty-duty advocacy by people who are smart in this space and are not me, right? But I think having that resource available and maximizing our ability to take advantage of it, I think has potential. I think there's evidence out there that things like a violence intervention program will benefit the health system by reducing uncompensated cost of care down the road. That's not the thing that's most motivational to me because, I think it's something we should pay for to make people better anyway. But, hospitals are so incredibly expensive that if you prevent one readmission, you can pay, your violence recovery specialist for 2 years or whatever, something like that. So there's some argument to be made on cost savings there. The next and last example is sort of speaks backwards to that in a different way. So I'll talk about something else. But Michelle, you had something to say.
Yeah, it's kind of almost slightly addressed with the cable lock, which I think is really cool that you kind of leverage this opportunity that was already happening.
Yeah.
For me, I'm not sure how much actual workplace violence goes on in hospitals and whether it's actually about that, but more about distributing these cable locks to the community, right? That might actually have the larger impact. And wondered if you thought about exploiting other opportunities. I don't know, like in courts, I'm sure they have that, or even some shops might have this kind of. I've seen in Michigan, they're like, you can't take your firearm into these places. Right. Whether this could be a wider intervention for just having.
Yeah. I was thinking about the courthouse recently also because I was. What was I doing? Oh no, because I was at the Capitol, and because they do have a storage place, right? So if you're trying to bring your gun, and if you're trying to bring your gun into court or into the Capitol, then they do have a place that you can store it. And I was like, okay, maybe they want to do this intervention too. It does feel very scalable in that way. It doesn't have to be healthcare. And so that's like on theme. It's like healthcare can also, I think it's healthcare, because I think injuries are health problems, and so it can happen in lots of different places with lots of different stakeholders. It's kind of neat. I don't know.
A really cool vehicle to actually distribute.
Yeah, I don't know if it works for workplace violence. I care about workplace violence, obviously, but that's not my goal. My goal is population health and safety in this context. So it's just an opportunity. To tag on to a process that exists rather than trying to get the health system to create a whole new process. I would say that's another thing that's probably important. Speaking of which, I gotta hurry up, so, which I knew was gonna happen. So now we're talking about something totally different, but, sort of aligned, which is insurance enrollment. This is how you enroll in Medicaid in Pennsylvania, and it says it's easy to apply, which is false, but, there's this opportunity of aligned incentives that we're working on at the moment. So there's still, after the Affordable Care Act, there's 27 million people in the U.S. approximately that are still uninsured. But about 60% of them are eligible for Medicaid or for marketplace subsidies and haven't enrolled for a host of reasons. I think, an acute care encounter represents an opportunity to connect patients to coverage. And about 40% of hospitals, including ours, has some kind of a linkage program to facilitate enrollment in insurance. And this is particularly for people who are uninsured and have to get admitted to the hospital. It usually doesn't take effect if you just go through the emergency department, but as I said a second ago, hospitalizations are really expensive. So this generally works, every state is a little different, but it generally works where if you're enrolled in, and it's usually Medicaid, during your admission or you start the enrollment process, then there's this thing called hospital presumptive eligibility, in which your coverage becomes retroactive and covers that hospitalization. So the acute care bill gets paid, which is good for everyone. It's good for the patient because they don't have that bill, and there's some great work out of the University of Michigan about the financial devastation that can come from acute care, and particularly in my world, trauma admissions. Minimizes unreimbursed care for the health system. Medicaid is not our favorite payer as a health system, but it is more than $0. And so it avoids catastrophic expenditures on both sides. So it's kind of cool. It's kind of nice. Lisa Knowlton and her group in California worked on this in the trauma space and found that about 70% of trauma patients who were in this hospital presumptive eligibility situation sustained Medicaid coverage at 6 months. There were some barriers to enrollment on the patient and the system side, and there's all this variation across states. But what I wanted to know was, is there a benefit beyond the bill? So now you have insurance. Are you then going to the primary care doctor and getting your blood pressure checked? Are you getting your mammogram and your colonoscopy? And I don't know. Patients without insurance are at higher risk of adverse presentations and outcomes, but insurance is not everything, as we know from a lot of evidence. So we wanted to know how well we're doing at enrolling patients, and then what happens to them, and how can we do better. So study one has happened. This is looking at Penn data to see whether people who get this form of insurance are going to the primary care doctor, and whether they're getting their post-acute care after trauma, and potentially whether they're getting elective or emergency surgery care, right? So if they have gallstones, can they go through the elective pathway, which is probably better for them and better for us, or are they coming back to the emergency department with an acute situation? We're working on qualitative interviews with the social workers and financial counselors who are involved in this process, and as well as with patients who are going through this process to try to make it better, or try to figure out how to make it better. And then we have a regional health information exchange in the Philadelphia area, which will I think next week. I was hoping to be able to tell you about this. Allow us to track these patients across other systems, because of course there's no reason they have to follow up at Penn. There's actually probably a number of reasons why they wouldn't be able to. And then I think there's potentially a host of things we could do to try to improve these connections to care. We haven't done any of them yet, just guessing. So we looked at this retrospectively in our electronic medical record data. And I'll take advice on this. There's no perfect comparison group. There's the people who remain uninsured, and there's people who already had Medicaid. So we used both of those groups, but it's not ideal, right? And we looked at whether they go to the doctor, whether they come back to the hospital, and what happens. So about 3/4 of people got insured via Medicaid. We don't have direct evidence on exactly why the uninsured people stayed uninsured. Some of it is that if you come in on the weekend or you don't stay very long, then the financial counselors don't have as much time. They will still make that initial connection, and they will call people after they leave, but getting the massive quantity of documentation that you need to complete an application becomes more difficult when people are gone. There's maybe a little bit less motivation on both sides because that bill is not as large, right? And people kind of fell in, whatever, patient characteristics. They're what you think. In terms of care usage, people kind of fell in the middle, which is also probably what you would think. They got a little more care than people who remained uninsured and a little less care than people who already had established insurance. That was true in terms of for people who had hypertension, getting their blood pressure in good control. That was true in terms of people with diabetes having a A1C that was where it belonged. People who were retroactively insured were more likely to have a PCP assigned, and in this set of data, that's the only indicator that we have that's across system, so they can have a PCP assigned anywhere, and it will pop up. So that's encouraging, I think, and we're more likely to see them as well compared to people who were uninsured. They were also more likely to see them compared to people with Medicaid, and I don't know why, but it's interesting. We think they also got, it's just the same story in a different context. They got a middling amount of their post-acute specialist care, so we think we're doing a decent job. We could maybe do a little bit better. There's a missing 25%. We think we're doing a decent job connecting people to care. We're currently not doing anything to connect people to care, so I think if we tried, we could probably do better. And there's opportunities there. I should have stopped already. That's my medical student presenting this work. Yes, arrives next week. I do think we'll get this next set of data next week. Our staff interviews are done, I think, and have been great. This is another one where it's kind of like a random part of the healthcare staff who turn out to be just so committed to their mission, and really open to working with us and trying to make it better, which I should be a better person and think better of people's commitment. I just always think people want to work less. So when people are signing up to say, hey, we want to do more, it's really cool. And then I think there's a million things we could do to try to connect this niche, vulnerable population to care. So I think healthcare isn't everything. I think it matters. I think we can do more. These are lists of people to thank just really for the point that this is all teamwork, and I couldn't remotely do any of it by myself. Okay, I'm going to stop.
So you asked, you said if anybody has suggestions about sort of how to think about trying to potentially estimate the impact of enrollment in Medicaid at the point of acute care admission. Mm-hmm. It depends on your N and the effect size, but the data you just described could potentially, I think, be amenable to an instrumental variables analysis, where the instrument is whether or not they came in on the weekday versus the weekend. Yeah. Which would essentially use that arguably random variation in when they were injured. Maybe it's not really. That's the question: is it truly random? Yeah. But would basically compare outcomes within people who were enrolled and who basically used that randomness to isolate an effective Medicaid enrollment for that group of patients without needing to use those two comparison groups, which are fundamentally pretty different. But it depends on whether, so it's theoretically an option. Whether or not it's like technically feasible depends on.
Right. Yeah, the day of admission might be kind of random, although I do think weekdays and weekends are different. And this is all comers, it's not just injury, so so that's a little bit more robust maybe in some way. The length of stay is not random. No. And it's also not unrelated to insurance status, especially if somebody needs post-discharge care. It's very hard to discharge an uninsured patient to a rehab facility, for example. So there's sort of like, so there might be something there. It would be nice if our health system would not do this program at some of its hospitals and do it at some of them, because that would be a little bit instrumental for us. Certainly some health systems do it and some health systems don't. So if we could acquire that level of data, that would be cool. There might just be pockets within our health system where we're doing a really bad job in a way that doesn't have to do with patient characteristics that we could exploit in an instrumental way. Yeah, I like this line of reasoning. I don't know. I do find in my limited experience with instrumental variables that they are, they consume a lot of power. So we had a few thousand patients in our group of interest and then a bunch of patients.
If you're talking about, like a couple of thousand patients, it's like, at least in the data that you quickly showed, it looked like the difference in likelihood of actually getting insured on weekdays versus weekends was, I don't know, maybe 10 percentage points, 15.
Yeah. So you might be able to do something there.
Yeah.
Yeah.
Might be possible, might be worth exploring.
Yeah, it is worth exploring. Cool.
Anyone else?
Other advice or questions?
Well, you said if you want to.
No, I wanted to. No, I'm serious. Advice on it.
Can I?
Yeah, keep advising.
No. I the first program that you described sounds really, really cool, and I think you talked about a lot about the economic needs of those patients, and I think definitely as you're like scaling up the program, looking for ways to study it, I would definitely like look for ways to measure longer term financial outcomes for those patients, right? Like their ability to, like, their not just employment, which is important, but like other measures of kind of financial security and like ability to pay bills and stuff like that, because you could see some really cool impacts there.
I just wondered with that finding that the ones that enrolled were using it more than the ones that were previously. Is that just like a novelty, or the fact that they had all this need that they previously weren't doing because they weren't?
This one, right, yeah, maybe you're more likely to see your primary care doctor in the first year after you get insurance because, you haven't been seeing anyone for a while. And this is, like, I would like to see that. I mean, probably most people are supposed to see a primary care doctor within a year in general. You're supposed to get a checkup or whatever. But yes, I would like to see people get insured and then see a doctor, like at a higher rate. That would be good. And then if we followed these people, maybe the next year, if they stayed insured, they would revert to where everybody else is, right? So
It also indicates an unmet need, right? So the fact that they went and saw them was that it wasn't that they didn't need it. It's just...
yeah, so there's some interesting studies out there in the world about what care people get when they're 65 compared to when they're 64. When they're eligible for Medicare, but probably their health is not that different on the population level. It's sort of a similar phenomenon to that, the wait list issue. Yeah.
And I would love you to set a precedent of Medicaid paying for firearm. That where you wish the
Paying for violence recovery services, yeah. Yeah, I mean, so it's, the policy exists at the federal level, states are taking it up. It's not trivial, the implementation is not trivial. Like I said, Connecticut is the furthest along, like they have the benefit established there, but the sort of quirks of the violence intervention programs that I know of in Connecticut mean that they haven't actually been able to use the benefit yet, which is frustrating because I want someone to do it so we can, like, you know, the California, Illinois is working on it. I don't know about Michigan.
We've started having conversations with the legislator.
Yeah.
They just haven't moved as fast as we want them to be.
Yeah, so I mean, and this is like one of those things where I will take this much credit for it. I didn't do anything in the advocacy, I didn't do anything, but I did mention the topic in a room with a person who knew how to make it happen and, you know, started having meetings with Medicaid. And so we're lucky, I think, in Pennsylvania that I don't think we need new law. So it's just sort of, it's in the administrative state, which the Pennsylvania legislature is pretty challenging, but any state legislature is going to, you know, new law is harder than no new law for sure. Yeah, it'd be pretty cool. Awesome. Thank you. Thank you very much.